Welcome to the Irish Practice Nurses Association online educational series for general practice nurses. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing the topic of cystic fibrosis. Cystic fibrosis is an inherited chronic disease primarily affecting the lungs and digestive system of over 1,300 children and adults in Ireland and 70,000 people worldwide. Ireland has the highest incidence per head of population of CF in the world, with 3 times the rate of the United States and the rest of the European Union. Between 2008 and 2016, an average of 38 individuals in Ireland were diagnosed with cystic fibrosis each year. Cystic fibrosis is a lifelong condition, and it usually becomes more severe with age, and it affects males and females equally. The symptoms and severity of CF vary from person to person. The majority of people have both respiratory and digestive problems. There is no cure for cystic fibrosis. However, life expectancy has increased steadily over the past 20 years, and today cystic fibrosis is no longer exclusive to childhood. To have CF, you must inherit 2 copies of the CFTR gene that contains mutations, 1 copy from each parent. That means that each parent must either have CF or be a carrier of the CFTR gene mutation. When 2 people who are carriers have a child, there is a 25% chance of having a child with cystic fibrosis. When one parent has CF and one parent is a carrier, there is a 50% chance of having a child with CF. About 2,000 CFTR gene mutations have been identified to date. Genetic testing provides important information to assist the diagnosis and treatment of cystic fibrosis. F508del is the most commonly detected CFTR mutation in Irish people living with cystic fibrosis. In 2016, 91.6% of the CF population had at least 1 copy. 15.2% at least 1 copy of G551D, and 5.8% at least 1 copy of R1178. All other CFTR mutations affect less than 5% of the cystic fibrosis population. 55.6% of patients living with cystic fibrosis in Ireland in 2016 had 2 copies of the F508del mutation. This compares with 46.1% in the United States and 50.3% in the United Kingdom. 36% of people had just 1 copy of the F508del mutation. The F508del homozygous mutation is the most common CFTR gene mutation in people under 40 years of age. In those over 40, F508del heterozygous mutations are the most common. Cystic fibrosis affects multiple organ systems, including the lungs, pancreas, upper airways, liver, intestine, and reproductive organs at varying degrees. Early diagnosis provides opportunities for earlier medical intervention. Providing infants with the best possible care results in better nutritional and lung function outcomes later in life. Optimized treatment prolongs the lives of people with cystic fibrosis, improving their quality of life. Improved diagnosis and symptomatic treatments have increased the survival rate of people with the condition from a lifespan of only a few months in the 1950s to a global median age of 40 years today. The predicted median age of survival for a person in Ireland with cystic fibrosis is early to mid-30s. Aside from symptomatic treatment, the first mutation-specific treatments have recently become available. Cystic fibrosis is caused by a gene mutation leading to dysfunction of the cystic fibrosis transmembrane conductance regulator protein, CFTR, a chloride channel of exocrine glands. The defect leads to diminished chloride secretions, which in turn leads to increased sodium absorption through epithelial sodium channels and removal of water from secretions, which become abnormally viscous. The effect causes obstruction, inflammation, and infection in the lungs and upper airways, tissue reorganization, and loss of function. People with cystic fibrosis present with a variety of symptoms, including very salty tasting skin, persistent coughing with phlegm, frequent lung infections, wheezing or shortness of breath, poor growth, weight gain despite a good appetite, and frequent greasy, bulky stools or difficulty in bowel movements. Symptoms usually appear in the first year of life, although occasionally they can develop later. The thick, viscous mucus in the body affects a number of organs, particularly the lungs and digestive system. Typical respiratory symptoms include cough and wheeze. Recurring chest and lung infections are caused by the continual buildup of mucus in the lungs, which provides an ideal breeding ground for bacteria. Two strains of bacteria that commonly infect people with cystic fibrosis are Pseudomonas aeruginosa and Burkholderia cepacia complex. They multiply in the thick mucus inside the lungs and may cause serious health problems and repeated chest infections. As more people with cystic fibrosis become infected with these bacteria, the bacteria become resistant to antibiotic treatment, which is why cross-infection is such a problem. Lung infections caused by Pseudomonas aeruginosa and Staphylococcus aureus can become chronic and cause an irreversible reduction in lung function. This diagram shows some of the classical clinical symptoms of cystic fibrosis, including lung inflammation, pancreatitis, nasal polyps, chronic sinusitis, infertility in males, parental short stature, miscellaneous Ig, and type 2 diabetes. The severity of the disease in the individual depends on variable organ sensitivity and on the genetically determined residual function of the CFTR protein. 97 to 98% of affected male patients are infertile because of obstructive azoospermia, and 87% of patients have exocrine pancreatic insufficiency. Disease severity, particularly the degree of pulmonary involvement, also depends on other disease-modifying genes and a number of factors including socio-economic background. Most cases of cystic fibrosis are diagnosed through screening tests carried out in early life. However, some babies, children, and even young adults are diagnosed later in life following unexplained illnesses. The main ways of diagnosing cystic fibrosis are through the heel prick test with newborn screening, antenatal testing, which is the chorionic villus sampling, CVS, carrier testing, which is genetic screening, and the sweat test. Chronic lung disease and paranasal sinuses varies among patients with cystic fibrosis and can be difficult to distinguish from frequent recurrent bouts of bronchitis or pneumonia, especially in young children. Children with cough, sputum production, or wheezing of greater than 3 months duration, persistently abnormal radiological findings, persistently positive bacterial cultures of respiratory secretions, or clubbing of the fingers should undergo diagnostic testing for CF, even if neonatal screening was negative. The same applies for children with bilateral chronic rhinosinusitis with frequent exacerbations with or without nasal polyps. Cystic fibrosis causes mucus to block the pancreatic ducts, leading to malnutrition, steatorrhea, and diabetes. People with cystic fibrosis who develop diabetes may find it difficult to gain weight or may lose weight and see a decline in their lung function. People with diabetes as a result of their cystic fibrosis need to take insulin and manage their diet to control blood glucose levels. Diabetes rarely occurs in children with cystic fibrosis. Pancreatic insufficiency is manifested by voluminous, fatty, shiny, malodorous pulp-like stools, abdominal symptoms, dystrophy, and deficiencies of fat-soluble vitamins, example hemolytic anemia due to vitamin E deficiency, and trace elements, example zinc dermatosis. The diagnosis can be established by a low fecal elastase measurement. Patients with primary pancreatic insufficiency are at increased risk of chronic and/or recurrent pancreatitis. People with cystic fibrosis are also prone to sinusitis and hay fever. Older children can develop a form of arthritis in the joints, such as the knee, which improves with time and treatment. Older children and adults are prone to osteoporosis due to repeated infection, poor growth or weight, lack of physical activity, and lack of vitamins and minerals due to digestive problems. People with CF are more at risk of developing osteoporosis if taking steroids to help with their lung infections. Osteoporosis as a result of cystic fibrosis may cause joint pain and cause bones to fracture more easily. Biophosphonates are taken to help maintain bone density. 1 in 10 babies with cystic fibrosis is born with meconium ileus and may require an operation. In nearly all men with cystic fibrosis, the spermatic tubes do not develop correctly, making them infertile. Women with cystic fibrosis may find that their menstrual cycle becomes absent or irregular, especially if they are underweight. There is an increased thickness of the cervical mucus, which may reduce fertility. However, most women with CF can conceive without any difficulty. If the bile ducts in the liver become blocked by mucus as the disease progresses, this can be serious, and in some cases a liver transplant may be necessary. There is no cure for cystic fibrosis. The aim of treatment is to clear and control infections in the lung and digestive system and reduce long-term damage due to infection and organ complications. Inhaled bronchodilator drugs are treatments used to relax the muscles surrounding the airways and help the person to breathe more easily. Antibiotics are prescribed to treat lung infections. All young children diagnosed with CF are started on a course of oral antibiotics to protect them, and that will be continued until they are 3 years of age. Steroids are used to help reduce the swelling of the airways, which can help with breathing, and DNase, an enzyme which is usually inhaled, is used to help thin and break down the viscous mucus in the lungs so it is easier to expectorate. Pancreatic enzyme replacement therapy, known as PERT, is required by most with cystic fibrosis due to pancreatic insufficiency. When the exocrine pancreas no longer functions adequately, the production of pancreatic enzymes is reduced, leading to fat malabsorption. The consequences of this includes steatorrhea, malnutrition, and fat-soluble vitamin deficiencies. Supplementary feeding includes oral, gastrostomy tube or button feeding, nasogastric tube feeding, or total parenteral nutrition may also be required due to continued weight loss. Pancreatic enzymes are taken before and during every meal and fat-containing snack or drink, helping the digestive system break down food so that it can be digested and absorbed. The number of enzyme capsules taken needs to be adjusted depending on the amount of fat in the meal, snack, or drink. The enzyme should be taken with the meal, and the timing may vary depending on the age of the person with cystic fibrosis. Fat-soluble vitamin supplements A, D, E, and K are taken to help replace lost vitamins and to prevent deficiencies. Biophosphonates are taken to treat osteoporosis, which can occur as a result of CF, to help maintain bone density and reduce the risk of fractures. People with cystic fibrosis should be up to date with all required vaccinations and should have the flu vaccine annually, as they are more susceptible to complications as a result of infection. Daily physiotherapy is usually required for people with cystic fibrosis. If a chest infection occurs, the airway clearance will need to be increased. Physiotherapy is tailored to the individual's needs. Physiotherapy for CF mainly focuses on airway clearance, but has expanded to include daily exercise, inhalation therapy, posture awareness, and in some cases for the management of incontinence. Some airway clearance techniques are done without the need for equipment and focus on specific breathing exercises, such as the active cycle of breathing techniques known as ACBT and autogenic drainage. Other techniques use devices to help the clearance of mucus. The devices use positive pressure to open the airways, while some create vibrations. Techniques include positive expiratory pressure known as PEP, oscillating positive expiratory pressure, and high-frequency chest wall oscillation. Cystic fibrosis transmembrane conductance regulator potentiators are the first available treatments that target the defective CFTR protein, the underlying cause of cystic fibrosis. CFTR correctors such as elexacaftor, lumacaftor, and tezacaftor correct the processing and trafficking defect of the F508del CFTR protein to enable it to reach the cell surface, where the CFTR potentiator, evactofer, can further enhance the ion channel function of the CFTR protein. Let's now look at some of the CFTR potentiators and correctors. Ivacaftor, or Calideco, potentiates the CFTR protein, a chloride channel present at the surface of epithelial cells in multiple organs. This facilitates increased chloride transport by potentiating the channel opening probability of certain CFTR gene mutations. It is indicated for CF in adults and children aged 6 months or older who have one mutation in the CFTR gene. It is not effective when used without a CFTR corrector if the patient is homozygous for the F508del mutation in the CFTR gene. Lumacaftor and ivacaftor, known as Orkambi, is a combination product containing lumacaftor, a CFTR corrector. Lumacaftor corrects the processing and trafficking defect of the F508del CFTR protein to enable it to reach the cell surface, where the CFTR potentiator, ivacaftor, can further enhance the ion channel function of the CFTR protein. Ivacaftor facilitates increased chloride transport by potentiating the channel opening probability of the CFTR proteins. The combination is indicated for cystic fibrosis in patients aged 6 years or older who are homozygous for the F508del mutation in the CFTR gene. This combination is well tolerated in young children. Tezacaftor, ivacaftor, Symdeko, and Symkevi are CFTR corrector and potentiator combination regime. It is indicated for cystic fibrosis in patients aged 6 years or older who are homozygous for the F508del mutation or who have at least one mutation in the cystic fibrosis transmembrane conductin regulator gene that is responsive to tezacaftor, ivacaftor based on in vitro data and/or clinical evidence. Trikafta, the first drug to treat the underlying cause of CF, was approved by the HSE in 2019. Trikafta is Vertex's first triple combination therapy and is the first approved treatment that is effective for CF patients aged 12 years and over with at least one F508del mutation, which affects 90% of people with CF worldwide and 80% in Ireland. It is anticipated that most patients on existing cystic fibrosis drugs such as Orkambi will transfer to Trikafta on the advice of their clinician. While news of the new drug is very welcome, the CEO of Vertex has emphasized that about 10% of cystic fibrosis patients remain without an available therapy because they don't make any CFTR protein. There's no combination of corrector therapies that will actually treat their disease because there's no protein to treat. The CEO of Cystic Fibrosis Ireland has said it is also why we need continued high international and national investment in research to ensure we have additional therapies for those patients for whom CFTR drug therapies will have no impact. In this context, Cystic Fibrosis Ireland remains determined to leave nobody behind. In severe cases of cystic fibrosis and when all medical treatments have failed, a lung transplant may be required. Lung transplantation for cystic fibrosis has a good success rate. 70% of people survive 1 or 2 years after transplantation, and the longest surviving patients had their transplant operation over 15 years ago. Deaths from CF in Ireland vary, but since 2000, an average of 18 individuals annually, age range of 7 to 31 years, have died. Better treatment strategies improve the duration and quality of life of people living with cystic fibrosis by controlling their symptoms. Improved treatments can be developed using patient registries. One of Cystic Fibrosis Registry's founding principles is to promote and facilitate the use of clinical data in approved research. The CFRI participates, among other European countries, in a long-term safety study of CF therapy, Evactor. Cystic fibrosis registries gather information on all aspects of a patient's condition, acting as information databases for infection and treatment statistics. Detailed analysis of this information yields significant findings about the most effective treatments for cystic fibrosis. Through this analysis, better management and improvement outcomes for individuals with cystic fibrosis can be achieved. Cystic Fibrosis Ireland is a voluntary organisation that was initially set up in 1963 to improve the treatment and facilities for people with CF in Ireland. CF Ireland, supported by fundraising and voluntary contributions, cooperates with medical professionals to provide maximum assistance to parents and children and adults with cystic fibrosis. CF Ireland provides funding towards new cystic fibrosis units around the country, including dedicated inpatient, daycare and outpatient facilities. They provide advocacy to shape government policy through the Pollock Report on cystic fibrosis services and campaigning to improve lung transplantation rates in Ireland. They help provide with funding for medical and scientific research aimed at understanding, managing and treating cystic fibrosis and providing funding for specialist cystic fibrosis multidisciplinary posts throughout Ireland. They provide advice, information and advocacy services, and they provide exercise, transplant and fertility grants, and they provide support for public awareness about cystic fibrosis and information updates on new treatments and developments. Cystic Fibrosis Ireland provides some very nice infographics on their website. On the left, you'll see an example of one of the infographics, which shows some of the Irish statistics and world statistics, information about symptoms and diagnosis and the genetics involved in cystic fibrosis. And on the right, you'll see a nice infographic on some of the treatments and therapies available, although it must be pointed out that some of the newer therapies that we have spoken about today are not mentioned on this infographic. Let's now consider the role of the practice nurse. Practice nurses play an essential part in the delivery of quality primary care, and we have a growing responsibility in the screening, assessment, treatment and management of many long-term conditions. A holistic person-centered approach is required in the management of patients with cystic fibrosis, providing ongoing assessment, management support and education. Key roles are to establish a therapeutic relationship with the patient, assessing their understanding of their condition, establish goals and expectations for successful management of their condition, and evaluate the physical, emotional, and psychological effects of the condition on their well-being. Other roles are advocacy and counselling, assessment, monitoring, audit, and evaluation for disease activity, progression, and the effects of the therapeutic regime on a patient with cystic fibrosis is a continuous process. The scope of practice nursing has evolved and continues to evolve. Many nurses can now prescribe medications, perform diagnostic examinations, and prescribe other types of medical treatments either independently or in conjunction with a doctor. We are leading the way in quality improvements initiative and research. By implementing person-centered care, monitoring and evaluating symptoms, outcomes and responses to therapy, practice nurses play a pivotal role in managing the illness and improving the patient's quality of life. This is a list of the references that were used in the production of this presentation. I hope you have enjoyed this presentation on cystic fibrosis, which is part of an online educational series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA. Thank you very much for watching and listening.